Hi. So today we'll be talking about hereditary angioedema. And here we see the diagrams of the SO1 inhibitor and the gene. It's located on chromosome 11. The gene is known as the serpin G1 gene. Now, it's produced in the liver as with most proteins in the body, and there's a place for androgens, for the effect of androgens. Some have said androgens help to increase the production of the C1 inhibitor, but ultimately it's produced in the liver. Okay, now moving on. The C1 inhibitor is from a group of inhibitors, a family of inhibitors, so to say, and we call them the serpin family of inhibitors, SERPIN. And they consist of the C1 inhibitor, the angiotensinogen, the alpha 1 antitrypsin, implicated in alpha 1 antitrypsin deficiency, and antithrombin 3, which is also helpful in reducing blood clots. This protein is lost in via the kidneys in patients with nephrotic syndrome. But here we are focusing on the C1 inhibitor. And what are the functions of the C1 inhibitor? Now, what we commonly know is that it inhibits the complement cascade responsible for innate, innate immunity and some people have acquired immunity by actually inhibiting C1 itself, especially the classical complement pathway, which starts from C1. It inhibits C1. But it also, but that's not the only function. That's other functions. It inhibits the clotting cascade too, by specifically targeting factors 12 and 11. It inhibits the fibrinolytic pathway also. And I mean, it inhibits a lot of pathways, but I guess the most popular one was inhibit the complement cascade, which is why it was named C1 inhibitor. Now, the one that is of particular importance to us is that it inhibits the kallikrein system. This kallikrein system is very, very important and it's implicated in the pathogenesis of the angioedema seen when we have C1 inhibitor. Now, this kallikrein system is ultimately responsible for the production of bradykinin. And as you may know already, bradykinin is responsible for a lot of things. And of particular importance is increasing capillary permeability. So research has shown that an increase in bradykinin causes some cellular and molecular changes, which ultimately result in increased capillary permeability. Now, when there's an increase in this capillary permeability, you'd expect that fluid is going to leak out into the tissue, and this is going to cause edema. So the major pathophysiology here is that C1 inhibitor inhibits this kallikrein system. Now, when there's a deficiency in this C1 inhibitor, the kallikrein system goes in overdrive, and you have a lot of bradykinin. When there's a lot of bradykinin in all the vessels of the body, you can expect that there's going to be an increase in capillary permeability, and you're going to have edema in different parts of the body, depending on wherever the bradykinin gets to. So, yeah, that's the basic part of physiology. You have a deficiency of C1 inhibitor or a resistance to C1 inhibitor or a dysfunction of C1 inhibitor, eventually leading to loss of the function where it inhibits the kallikrein system. When that happens, it's going to be an increase in bradykinin and you have increased capillary permeability and you're going to have generalized edema. Now let's look at the different places where we can find the edema commonly. Now, I want to show you that this edema is recurrent. It comes and goes, lasts for 1 to 3 days, it goes, comes again. Okay, so let's start from the subcutaneous tissue. Now, when it happens in the subcutaneous tissue, you tend to have edema in the subcutaneous tissues of the face, the arm, the genitals, and the buttocks. So the patient can come with just this spontaneous edema, which is not itchy, of the face and of the arm, of the buttocks, of the legs, of the extremities. Just recurrent spontaneous edema. Okay, so that's the first one, edema of the subcutaneous tissues. Recurrent. Yeah, so increase in bradykinin causing edema of those places. Yeah. And remember, the edema is recurrent and it has some triggers. Now let's move on to other places where um, we see recurring edema. Now, in the internal organs of the body, we also find edema. And when I mean internal organs, I mean starting from the gastrointestinal tract. You have the stomach, the intestines, all down to the anal canal. You can have edema of those places. You will have edema of the kidneys, some of the other organs. So if you have edema of this mucosal lining, they're going to come with some specific signs and symptoms. Imagine someone just having an edema of stomach and intestine. They're going to come with abdominal pain, recurrent abdominal pain, recurrent vomiting, recurrent diarrhea. And when we do ultrasound, we may see thickening of the mucosal walls of these internal organs. So that's another feature that can be seen in the edema of the stomach, the intestines, the kidneys, and ultrasound. You're going to see increase in the mucosal wall thickening, and you have signs and symptoms like pain, vomiting, and diarrhea. So yeah, that's it. So edema of the intestine, kidneys, um, leading to signs and symptoms like pain, vomiting, and diarrhea. Okay, so moving on, we also have affectation of the mouth and the larynx, right? The mouth and the larynx and the tongue. You could have edema of the tongue, the mouth, the larynx, and this is particularly dangerous because when you have edema of those places, there's going to be difficulty in breathing and it can be fatal. So that's one thing to look out for: edema of the tongue, the larynx, the mouth, the throat, basically, and it's recurrent. So you can manifest in any of those three ways. You have edema of the subcutaneous tissues of the face, there's have edema of the intestines, the stomach, and you could have edema of the mouth, tongue, larynx, causing difficulty in breathing and dyspnea. Okay, yeah. So now we've seen the different signs and symptoms that they could come with. Let's look at some other things. We've said that these episodes are recurrent. You have an acute deficiency in C1 inhibitor, leading to increased bradykinin, leading to increased capillary permeability and edema. But what triggers these episodes? Trauma and infection have been seen to trigger this. If you have a mild trauma somewhere, it could trigger an angioedematous episode. Likewise, if there's an infection. And one thing that's characteristics about this is that it is unresponsive to antihistamines. Of course, mast cells are not implicated in the pathology, so they won't respond to antihistamines. They last 1 to 3 days, and it can last up to about 5 days or thereabouts. Now, another thing that's peculiar about this is that if you do the laboratory investigations, the baseline laboratory investigations, the full blood count is going to be normal. You're not going to see eosinophilia. You're not going to see an increase in erythrocyte sedimentation rate because it's just recurrent. It comes and goes. It's spontaneous. So you don't expect an increase in ESR. And the pathophysiology, like I stressed again, is not allergic. So you're not going to see eosinophilia. What you would see, however, is a decrease in the level of C1 inhibitors if it can be acid and a decrease in C4, in the fourth part of the complement. The C4 is part of the complex that also binds to C2 and to form the C3 convertase, which is important in the complement uh, pathway. Yeah, so remember all this starts as a result of C1 C1 deficiency. Okay, I hope at this point you've had a full grasp of the pathophysiology, how it progresses, what the molecules that are implicated in this condition called hereditary angioedema. You should also know that this kind of angioedema can be acquired, just that there's no genetic basis for the acquired angioedema. edema. So, how do we treat? You replace what is deficient. C1 inhibitors are deficient. You replace it by giving concentrates. Okay, there's an increase in the function of the kallikrein system. We need to increase bradykinin. We can give kallikrein inhibitors to reduce that. So, C1 inhibitors, kallikrein inhibitor, and you can also give fresh frozen plasma because this has been said to contain C1 inhibitors. Now, we could also give androgens for prophylaxis. Remember, we said earlier that androgens have been implicated in production increase. So, if we can give androgens, we should be able to increase the production of C1 inhibitors. Thank you again, and I remain Dami, MBS.